Hello and welcome to today's second webinar. Thank you so much for taking time out and being here. And my name is Young and I am the moderator, as you can see. And also I am the marketing and educational seminar coordinator here at Neobiotech. So hello and welcome back again. And also, please stay connected with us on social media. Our Facebook page is Neobiotech USA, and also our Instagram page is Neobiotech_USA. And lastly, YouTube channel is Neobiotech USA. So follow us, and also you can see all this up-to-date information from our social media. And today's agenda is very simple. I will introduce our topic and presenter, and then I will also make an announcement right after the lecture in regard to the upcoming webinars, as well as watch previous webinars, and also lastly, how to receive your C credits. So please stay until the end. Yeah, we are. So today's agenda, today's topic is the to start surgical placement of dental implants, part 1 with Dr. Kent Hwang. And we will have a Q&A session at the end, so please submit your questions through this Q&A box. And one thing that I want to address is Dr. Hwang may not answer all of the questions since we have a short period of time, but you can feel free to send an email to Dr. Hwang and he'll feel free to answer some of these questions. So let's start. Let's have the Dr. Hwang to start today's webinar. Okay, let me see. Good afternoon, Dr. Hwang.
Hi, hold on.
There you go.
There you go. Hello, how are you?
I'm doing great, doctor. Yeah, I will pass it to you to start the webinar.
Sure. All right. Hi, everyone. I'm going to go ahead and jump right in to my, oops, here we go. So first of all, thank you for joining me here during this COVID-19 time. Okay, I hope everyone's staying safe. I'm going to go over how to start surgical placement of dental implants in your practice. This is pretty basic. For those who have been placing implants, this is going to be a lot of review. Maybe you'll pick up on a few little key things that might be new to you, but might be a lot of review. I hope that you get something out of it. And for those of you who are really new to implants, I hope that this will open up your practice to more potential, and I hope that I help, okay? If you have any questions to my lecture, you could always reach me on my email address, which is right here to the right of my screen here. And I'll give you my email later also, okay? Let's go ahead and start right away, go into the lecture, okay? All right, oops, sorry. You have to first ask yourself this question, okay? And that's, which dental practitioners has the responsibility for long-term care of implant patients, okay? Once the implant is done, who takes care of the patient? And that's the more important one, because once the implant is placed, then it's the aftercare, that's the long-term commitment, okay? And that responsibility falls on the restorative dentist. That's the general dentist and prosthodontist, okay? So therefore, it is imperative that general dentists understand implant dentistry. Whether you place it or not, you have to understand, okay? Because this is part of our life, our dental life. So we have to, as a general dentist, be responsible for the aftercare. So we have to understand what's going on. So why do GPs not place implants? Simply, we get overwhelmed or confused. And to start, look at what implant system do you choose? There's obviously Neobiotech that I use, and there's Dentist, Megagen, Hyoscine, Bicon, Zimmer, MIS, Straumann, Astra, Alpha Bio, Novo Biocare, tons more, okay? That's endless. What about equipment? What's required? You need CT scan, people say. We need 3D cone beam. There's so many different companies, How about the field of view, FOV? There's different sizes that you could get, and the cost is going to be varying also depending on that size of view, okay? So it's kind of intimidating. How about implant motor? There's so many different implant motor, and the cost can be very different too. How about surgical kits? They look so confusing. They're colorful, but they have tons of parts. What are all these parts? And different companies have different layout. It just looks overwhelming for someone who's never had to look at this, okay? Someone who's new. And also as GP, we think that surgical procedure is very difficult, that only specialists, oral surgeons, and periodontists should place dental implants. This is a huge myth. Many general dentists believe this. However, worldwide, 80 to 90% of general dentists place implants surgically, but only 10 to 15% do in North America. Why is that? Placing dental implant is difficult and takes long chair time. This is what general dentists think. If they're not doing implants, they're scared. Actually, a single implant placement in a sufficient bony ridge is much easier and quicker than a class 2 composite or a single canal RCT. Okay? So I know you guys do, girls and guys out there, you all do composites, you all do canal, single canal, root canal. This is going to be even easier than that once you understand. So let's simplify this procedure. Okay? I like to inform you about Paretos Principle by Vilfredo Pareto, Italian man, known also as the 80-20 rule. Okay? This says roughly 80% of the effects come from 20% of actions that we do. Okay. In dental implants, look at this. Approximately 80% of implants placed are single unit restoration. So out of all the implants that we're placing, 80% are one single unit, okay? With 70% of those being in the posterior region. And out of that, 30 to 35% of those being the lower first molar. Okay? So that's very comforting. You can do this, okay? I'm gonna show you a case, typical. First molar is missing, okay? It's also because it's the first permanent molar tooth coming in the posterior. And we don't take care of our teeth, so it's the first tooth missing, obviously, okay? This patient comes in, and this is a pre-radiograph, pretty straightforward. I look in, patient has wide ridge, plenty of keratinized tissue, everything's looking perfect, okay? So I just do an infiltration and then do a simple tissue punch, okay? And I go through the osteotomy. This is a parallel pin just to see the position, okay? After I do the next drill, I flip over the parallel pin to still see how it's going. And this is the healing abutment after the placement of the implant. This is the final radiograph. This took literally 5 minutes for me to complete. I'm not saying that it'll take you 5 minutes initially if you've never done an implant before, but having a couple of experiences, something like this really should not take more than half an hour. I think it's going to get to a point where it's going to take about 10 minutes to 20 minutes at the most for something like this, okay? And actually, when you do a procedure like this with the tissue punch and do it so fast, it's less trauma to the patient. Patient really doesn't have any pain, and you're going to get a lot of referral. Okay? So how to succeed financially and emotionally in implant dentistry? We want to make a lot of money and be happy about it, okay? How do you do it? You just do it. You have to start, okay? That's the problem. Most doctors don't start. That's why we don't get into it. But if you start, you'll get there, okay? So that's the thing, you have to start. How will it affect your office? My average implant, we charge about $2,500 each, okay? So if you place one implant a week and there's 52 weeks in a year, that translates to approximately, well, exactly $130,000 a year, okay? That's just placing one implant a week. How about if you place 2 a week? Obviously, you double that, you get $260,000 a year. Okay, how about if I place one implant per day and I only work 4 days? Okay, I have 3 days off and I only work 4 days. So we place one implant a day, 4 days a week. That is 520,000 a year. Okay, we have in our practice been consistently producing over $1 million a year. Okay, and this is not just a year or two. This has been the case for the past 18 years or something. Okay, so I want to challenge you to start by setting a goal of one implant every other week. That's not even one a week. It's every 2 weeks or 2 implants a month. You're going to get a start of $65,000 a year in growth. Okay, and I think once you start, it's like a snowball effect. Once you start, it gets going. You'll find enjoyment once you start with the easy cases. So I say start with a goal of one implant every other week, okay? And I know you're gonna have plenty of work because right now with the COVID-19, we're just seeing emergency patients, but with all this stress, we're finding that a lot of patients are coming in with broken teeth, broken fillings, and so forth, or root canals and so forth. Those are all potential implants. Okay, so let's look at the anatomic considerations in implant surgery. Okay, we're dealing with bone because if we're placing implant, we're placing in the bone. We have to understand resorption pattern of residual bone ridge, alveolar ridge. This diagram, we've gone through it so many times, but the maxillary ridge resorbs like the way it shows on the upper left here. Okay, 0, 1, 2, 3, 4, 5, 6 is a progression of the phases, and then below that is a mandibular. Okay, so these are something that we all know about. Okay, let's divide it into mandibular arch and maxillary. So if we look at the mandibular arch, what are the things that we have to worry about? The main thing is the inferior alveolar nerve. Okay, we always hear about this. And implant dentistry on the mandibular, vital organ is the inferior alveolar nerve. This is the way it looks. Okay, and if we had a panoramic X-ray, if we drew it out, this is what it looks like. And you obviously, this is the one that you're looking for in the red. You're looking for the inferior alveolar nerve, okay, and how it enters and exits into the mental foramina. Okay, how about if the bone in the posterior resorbs quite a bit? Then you hear about the all on 4, all on 5, and so forth between the foramina, the mental foramina, to provide adequate mechanical stability. This would be affixed, okay? And that part is usually the area that has the most bone, the mandibular anterior, okay? So you have the all on 4, all on 5, and you have the distal extension that's possible. So if you look at the fixture superstructure, where you hear this AP distance and the X, which is the X is the distal extension. How far back can you go cantilevering off an implant? If you have the AP distance, AP stands for anterior posterior, okay, distance. It's studies have shown that you could go 1.5 times AP distance. Obviously, the shorter the distal extension, the better it is for function-wise. But the maximum they've shown is about 1.5 times AP. The AP distance is a perpendicular distance, okay? It's not a curvature thing. It's the most front to the most back of the implant, okay, that you place. So also, when you have something like this where it's all fixed in one unit, precise fit of the superstructure is critical. Okay, how about the inferior alveolar nerve? You know, you hear about placing an implant minimum 1 millimeter away. I recommend 2 millimeter away from the IA nerve. And this will become more evident once I go through the drilling sequence and the actual drill size, okay? But you want to be, in my estimate, 2 millimeter away from the IA nerve when you're drilling. And then in the posterior, you have to be careful of the lingual artery of the mandibular because there's a lingual artery that goes toward the in the area of the molar area, okay? If you go lingually, you could go through the lingual plate and hit the lingual artery. The problem with the lingual artery is if you hit it and it bleeds, you know, you hear about this all the time in dental school, that it can kill a person. And the reason why it kills a person, they don't bleed to death, it's the suffocation. What happens is the bleeding causes the tongue to gorge and constrict the airway. So the patient dies of suffocation, okay? Airway suffocation. Okay, mental canal and mental foramen. This will be usually around the premolar, usually between the first and second premolar. Usually we'll see this in the panoramic x-ray. You could see it in a PA or a CT. Okay. Lingual fossa, I talked about this just a little bit earlier. It's usually below the first and second molar area. Okay. You could feel this with your finger if you just palpate on the lingual side of the molar area. So this area, you have to be careful when you're drilling, you're going straight, and what you'll feel is, you'll feel a hard bone. When you go, initially you go through cortical plate, so you feel a hard resistance, and then you go to cancellar bone, it's softer drilling, all of a sudden you hit a cortical, you hard bone again, way before your final length. Then you have to really be careful and look into it, because you might be hitting the lingual cortical plate. And I wouldn't recommend pushing through. I would take another radiograph and so forth, and to figure out what's going on, okay? Fixture distribution. You want a distance between natural tooth and an implant fixture to be around 2 to 3 millimeter at least, okay? So if you look at the drawing here on the left, you want between that premolar and that first implant 2 to 3 millimeters away, okay? And then between the implants, you want 3 to 4 millimeters away. That's pretty straightforward. And then how about occlusal clearance? There's 2 different kinds of implant restorations that we do. We do a cement type and screw type. If you're doing a cement type of restoration, you need a minimum of 6 millimeter of interocclusal clearance due to the axial wall necessary for cement retention of the crown, okay? And that is this distance right here, okay? So if this distance is less than 6 millimeter, you're not gonna have a situation where you could have a good retention with cement type, okay? You might have to do intentional root canal on the opposing, or alveoloplasty on the implant site to get more interocclusal space. For screw type, you need a minimum of 5 millimeter clearance. And this is due to the abutment screw, the size of the abutment screw head. If you have less than that, you potentially can obliterate the hex in the abutment screw, which will cause problems in the future, okay? So let's look at the maxillary arch. Okay, maxillary anterior, this is the hardest region to work on, and it's because of the nature of the maxillary anterior. It has a thin facial bone, and due to the anterior, there's an anterior concavity due to the anterior flare of the teeth there. So you have to be careful how you place the implant here. Maxillary alveolar arch morphology, if you look at it like the diagram here, the posterior area, there's usually a 5 to 10 degree buccal inclination, okay? So there's an inclination inward buccally, so you have to be cognizant of that. And in the anterior region, you have a thin labial alveolar plate, like we've always talked about, and there's a labial flare of the teeth, okay? And the maxilla is composed of cancellous and spongy bone, okay? If you look at a typical one like here, a patient comes in because this patient is missing the first molar in the upper right. These are ones that you really have to be careful of, because this area looks okay, right? But if you flap that area because of the concavity and so forth, you'll find that there is very deficient bone. You definitely need to do bone grafting here before you do the implant. Okay. How about incisive nerve and greater palatine nerve? The palatine, you don't really have to worry about in implants because we really don't flap in the palate that far. In the anterior incisive, we do sometimes flap, and we get a question, are you worried about damaging the incisive nerve? You really don't have to worry about the incisive nerve. You could actually go in there and cut out all the nerve in the incisive canal, and you could even place an implant in there. It won't cause any problem, okay? So incisive nerve, you really don't have to worry about. Okay, how about blood supply to the greater palatine artery is in the diagram here. You really don't worry about it in implant dentistry because we don't really make flaps that far usually. But only time that you really have to worry about is during connective tissue graft harvesting. So if you're doing connective tissue graft and you're harvesting from the patient, you have to make sure you don't cut that. It causes a lot of bleeding, okay? Maxillary sinus, this is how it looks in the cut. I talked about this in my sinus lecture, but this is the sinus is shaped like a pyramid. It's an air-filled cavity. It reduces the skull weight. It produces mucus. It affects tone quality of a person's voice. It affects implant position placement because of that, okay? Blood supply to the maxillary sinus, we talked about this again. It's a division of the maxillary artery, which involves the inferior orbital artery, which is not really a concern when we're doing implants. Posterior superior alveolar artery, and the branch of that, intraosseous and extraosseous, is the one that we're more concerned about when we're doing sinus elevations and so forth. Schneiderian membrane is the lining of the sinus. I talked about this in my sinus course, but it's just a ciliated membrane that moves mucus, okay? It has great properties for us to be able to do sinus elevation. Okay, understanding Neobiotech stop drill, okay? I'm hoping that I get to go in this little more detail, okay? So let's go through. This is what the Neobiotech stop drill looks like. It's a version 2, okay? It's actually very pretty, I think. Very simple and very intuitive the way it's designed and laid out. And these really read like a book. It goes from the left to the right, from top to bottom, okay? And it's, once you figure this out and go over it, it's a very simple kit, okay? I'll go in detail. If you lift that top tray, underneath, there is this one instrument, okay, that comes in very handy, and I'll explain this. Why is it called the stop drill kit? It is because there is a stop to prevent drilling further, okay? So there's a shoulder stop here that prevents you to drill any further. It stops it from drilling deeper. So that's why it's called the stop drill kit. Okay. So once again, if you look at the overall layout of this stop drill kit, you read it from the left to right, up to down, top to bottom, okay? And I'll go over step by step. Okay, the first drill on the upper left corner is called the Lindemann drill, used as a point drill to initiate an osteotomy to prevent slipping, okay? Because it's pointed, you could get a nice start when you're doing an osteotomy. And in my lectures, I usually tell my doctors that you don't always have to use this one. What I find was helpful for me when I started was I used a high speed, regular high speed, and I put in a 557 or a 330 or just a chamfer diamond, whatever is most comfortable in my hand. And I go through the cortical plate of the osteotomy. That's the most difficult or most challenging or part of the implant surgery, is initiating that first drill, okay? So once you get past the cortical plate, it makes it much easier. So you can use a high speed and your favorite burr, whatever it is, if you want it. But if you didn't want to take out your high speed with this and the Lindemann drill, you can initiate the drilling, okay? And if you notice, there is a serration, side cutting serration. It allows us to change direction, okay? That's if You go in and you don't like the angle, you could kind of lean to one way as you're going, and you could change the direction of drilling. So that's the Lindemann drill. Now, if you look at the main part of the kit, you have, see on the top, it says initial drill 3.5, 4.0. Okay, so let's divide that. Initial drill 2.2 millimeter diameter, the gray area on the far left, they're all 2.2 millimeter diameter, but if you go from top to bottom, they're different in length, okay? So that's what it is, okay? And then you have the other side, all of those colorful ones. That's what I call the final drill. It's to determine by what your final implant size is going to be. So if your final implant size is going to be 4.5 by 10 millimeter, it's going to be right in the middle. 4.5, that light blue, 4.5 diameter. And if you go down to 10 millimeter, that's your end final drill. That's where you're trying to get to. Okay. All right. So stop drill kit, like I said, each diameter has different drills for different stop length. So this green band around the drill here is denoted for 4 millimeter diameter implant fixture, okay? But for different length, there's different stop drills. The first one is the 7.3 millimeter stop. And these all correlate with the Neobiotech implant length. They have a 7.3 and a 8.5 millimeter. So obviously there's an 8.5 millimeter stop and a 10 millimeter, 11.5 millimeter, and a 13 millimeter. I hardly ever use 13. My favorite is, my go-to is a 10 millimeter, but they have 5 different lengths. Okay. The initial drill, I'm gonna go through each one a little bit more in detail because we really need to understand these drills to be able to do your work properly. These are tools. So you just have to learn the tools and what it is and figure out what the engineers designed into it, okay? So here you have the initial drill is used to initiate osteotomy, position, depth, and angle, okay? Why isn't it going through? Sorry, something is not. I'm having technical difficulty. Where's my, sorry, hold on. Let me try that again. There it goes. Okay, the initial size, 2.2 millimeter right here. It says 2.2 millimeter diameter by 10 millimeter in length. So 2.2 is that diameter here, and 10 millimeter is the length, okay? There's a stop right here to prevent you from going any deeper, okay? The twist drills, they have 2-step cutting tip design. So if you look at here, the top part is narrower than the second part below. This is, the purpose is to help guide the next drill in the sequence, okay? But if you go into the wider drill, the wider meaning 4.5 millimeter or greater, then there is a 3-step cutting tip, as you can see here, okay? And this is to prevent heat necrosis in dense cortical bone, mainly in the lower molar site, okay, where you're putting in large implants and wide implants. And the mandibular arch has a thick cortical plate. So if you are jumping into a wider diameter cutting, then the heat produced by that cortical plate can cause heat necrosis. So there's a 3-step cutting tip, okay? Okay. Final twist drill, if you look at these, you have the size marking here on the laser marking on the right here. It says 3.0. That circle with the hash, that's a notation for diameter. So 3 millimeter diameter by 10 millimeter length. And the orange band is for the fixture size. So if you look at the picture on the bottom left corner, you could see the orange, it correlates to 3.5 millimeter diameter. But look at the diameter of the cutting surface. It's 3 millimeter. So there's a difference between the osteotomy, the hole that you're creating, which is 3 millimeter, but the implant you're putting is 0.5 millimeters wider. Actually, there's a differential of 0.6 millimeters, but I think that's a harder number to remember, so we put 0.5 millimeter differential. But you want that difference so that you get initial stability, okay? And this is used to create desired diameter and depth, okay, the final. So you want to go to the final drill that you want for the implant size. Here, you have to look at this drill tip. I'm saying it's 1.2 millimeter. That's the cutting tip. That's right here. So actuality, the drill is, instead of 10 millimeters, it's 11.2 millimeter long. So there's a 1.2 millimeter extra at the length, at the tip. That's to cut the bone, okay, initiate the drilling. So yeah, that's why I said if you're near the inferior alveolar nerve, you don't want to be a millimeter away from it. You want to be 2 millimeter away from it just to be safe, because there is a cutting edge, 1.2 millimeter cutting tip. So if you're only a millimeter away, you take the risk of touching the inferior alveolar nerve. Cortical drill. The cortical drill is used to expand the osteotomy at the cortical bone, the top part of the osteotomy, and to prevent compression necrosis in the mandibular arch. Really, this cortical drill is not used in the maxilla, it's only used in the mandibular arch, and usually in the mandibular posterior, okay? You can use it in the mandibular anterior also. It's mainly to create a larger osteotomy at the cortical, because remember the final drill is 0.5 millimeter smaller than the actual implant. So if the cortical plate is really thick, they could cause a lot of compression necrosis. So you want to widen that. And notice the depth marking here, okay? So you don't want to go all the way to the stop, okay? You want to go up to the marking. If you go all the way to the stop, then you take the risk of losing stability. And then the parallel pins. There's a lot of information here. I'm sorry that it might be confusing, but there's 3 different sizes of parallel pin that comes in the kit. One is 7 millimeter, the other one is 8.5, and then 10 millimeter. What that is the length. So you see on the 7, double arrow, that's a 7 millimeter. And then the one below that, 8.5, is a longer. So that's that. And then the side that I said, this side after 2.2 initial drill, that's the side you check with after you do the initial drill. You put this in and check to see the position of the osteotomy, okay? And then if you're happy with that, you go to the next size, which is a 3.0 twist drill. And then to verify that you're progressing properly, you could flip these parallel pins and verify with the other end, okay? And here's one thing that you have to look at. The hole, there's a hole for floss to pull out of the patient, pull out if a patient accidentally swallows it, okay? So there's a hole, you put a floss in there and tie it up so that these are pretty slippery, can be pretty slippery, and patients lying on their back and it could go and they could aspirate. So that's what that hole is for. Cortical tap. These are here on the lower left. There's different ones. There's ones for IS2, IS3. That's to correlate with the exact shape of the implant thread and width, okay? This is used to create identical form on coronal portion to prevent pressure necrosis in D1 bone, okay? Mainly used for mandibular arch. Implant fixture driver, that's the silver component there, used to deliver or insert implant fixture into the prepared osteotomy. Here, what I want you to look at is that yellow implant is actually a dummy fixture. doesn't come with that. But if you see where the yellow fixture butts up against the yellow marking on the fixture driver, that's what you want. You don't want a situation like this where it's not touching. So you have to make sure the implant or the orange line here is all the way touching the implant fixture to make sure it's seated. If you don't do that, then you're gonna drop the implant when you're delivering. Okay. Drill extension, that's the thing on the bottom here, the silver one. It's used to extend the drill, used primarily in the lower and upper anterior region if there's adjacent tooth, okay? Because if you just use the twist drill, the head of the implant drill can touch the adjacent tooth and prevent this from going all the way to down. So you only use it in the anterior because if you extend this in the posterior, it's hard to get it into the patient's mouth in the posterior. So usually used in the anterior region. Okay. The connector, it has an internal hex. The main two used for this is one to connect with cortical tap to hand tap or remove cortical tap that is stuck. Okay, this happens when you're using the engine to cortical tap and you forget to change the RPM and it just drives in there sometimes, and then in the lower posterior, it'll just get stuck. Then the engine can't torque it out. So you have to just dislodge from the motor, put this on, and you could use a torque wrench to reverse that out. The second one is to connect with the contra-angle fixture driver to extend the fixture driver length. I wish I was there in person to show you how this works, but that's what it's for. Okay. The torque wrench and ratchet used to measure torque during fixture seating, okay, using the bar there. And you can change the direction by pulling that pin slightly and turning it to change the direction of ratcheting, okay? So that here inside is what allows the torque wrench to go one direction. But if you pull the end and turn it, it goes the other way, okay? So that's what that is trying to show. Underneath the main compartment, there's a driver holder and a depth gauge all in one, okay? Depth gauge is to the left to measure the depth of the osteotomy, and then to the right is the driver holder. What that is like this. The driver holder end, it's a plastic end that snaps into the hex driver, okay? And there's a swivel. That part is swivel action. It's kind of nice because it holds that position pretty well. And if you look at the hex driver, you see that hole at the end, the green end, not the middle hole, but on the side. That's actually for the floss. If you want to put a floss there, you could tie a floss there, so if you drop it, you could pull it back. But with the driver holder, it snaps in. You don't really need the floss, okay? It locks in like this, and it freely rotates. So you hold the handle, and then you put this in there and start turning. Okay. The depth gauge on the other end, you'll see laser marking here, and it corresponds to the handle. So if you look at where the blue arrow, long blue arrow is pointing on the left side, the bottom of that thick band corresponds to 5 millimeters if you look at the handle there. So you could see that if the osteotomy goes to that line, then you know you're in 5 millimeter. And also at the tip of that depth gauge, you notice that it has a blunt end, so it's very safe. You could put it in the maxilla. You don't have to worry about puncturing. So this is a great tool to check how your osteotomy is going, okay? So drilling protocol, okay? Drilling protocol for Neobiotech implant. Here, we're gonna go through a drilling sequence. This is a typical, if you look at the bottom left here, D1, D2, that's the bone quality of the bone we're working on. And we're planning to put in a 4x10 implant fixture. So this would be a typical sequence in that kind of situation. You have a Lindemann drill. You start the osteotomy to go through the cortical plate, and then you use a stop drill 2.2, initial drill 2.2 by 10 millimeter, and go all the way to the stop, okay? And then you go to the next one, which is a 3.0 by 10 millimeter, go all the way to the stop. And then you go to the 3.5 millimeter by 10 millimeter, and go to the stop. And then for here, because we're dealing with D1 bone, cortical bone, you want to do a cortical tap, only on the cortical portion. And then you deliver the implant. But once again, I want you to focus on this, the drill tip, okay? There's 1.2 millimeter cutting edge right here. So it's actually a little bit longer, as the diagram shows. Beyond the 10 millimeter, you have a 1.2 millimeter deeper cut. So that's why I said, instead of 1 millimeter away from the IA, you want to be 2 millimeter away pre-surgical, okay? When you're treatment planning, you want to be 2 millimeter away from the inferior alveolar nerve. Okay, so let's go more in detail how it goes. So the initial step is on the left side here. I do an incision or a tissue punch, okay? And that's with high speed, if I'm doing tissue punch on the implant motor with irrigation. And then the next drill I would do is a Lindemann drill with irrigation at about 1200 to 2000 RPM. That's a high RPM. And the torque, you set it at 30, 45 newtons per centimeter, doesn't really matter, okay? And then after that, you go to the 2.2 initial drill, 2.2 by 10, because we're looking to put in a 10 millimeter implant. So we're gonna go to depth of 10 millimeter with the initial drill. And this is done with irrigation anywhere from 700 to 2000. I'd like to keep it in a high RPM because I have better control at a higher RPM than a slower RPM. So I keep it at 1500 to 2000 RPM with irrigation, and I go all the way to the stop. So this will create a 2.2 by 10 millimeter hole or osteotomy, okay? So I check with the depth gauge to make sure that I went into the bone 10 millimeter. And after that, I put in the position pin, parallel pin, to see how it's positioned against the adjacent teeth, if the angle is correct. And also, if possible, I like to have the patient bite down and see where the parallel pin points to. It should point to the opposing marginal ridge, okay? That's how our teeth are meant to, the center of the pin should go right toward the marginal ridge, the opposing. That's the ideal, okay? After that, you progress to the twist drill, 3.0 by 10 millimeter with irrigation, and I reduce the speed to 700 RPM, okay? Same torque, 30 to 45 newtons per centimeter. And then after that, I go to the next one, which is a final twist drill, 3.5 by 10 millimeter with irrigation at 700 to 800 RPM with 30 to 35 newtons per centimeter again. And then, because we're dealing with the mandibular cortical bone, I do a cortical tap. I use a 4.0 diameter cortical tap, and I do this at a slow speed. This is where I told you that some doctors who are new make an error. They forget to reduce the RPM. They still have it in 800, 700 or 800 RPM, and they put this in and step on the pedal, and this will just drive in. What happens is, if you did that, it'll lock in that drill. And if you try to reverse it out, it won't reverse out because there's too much pressure, okay? In that case, you disengage the handpiece by pressing on the lever, and then you can put the connector on that and use a hand ratchet to reverse that out, okay? So that's if you have an error, okay? If you don't have an error, everything's going correct, after the cortical tap, you place the fixture and you're done, okay? And I put the fixture 0.5 to 1 millimeter deeper than the crest. So here is a protocol for different types of situation. If you have on the top, what it is D1, D2 bone, then you're gonna drill a little bit more, tap a little wider, tap also. And so if you have a D1, D2 cortical and D3 below, then you go through the next one. If you have D3, just like maxilla, you undersize drill, okay? And those, you have another one was D1, D2, and D4 inside, so forth, okay? So that's that. Let's look at this. If you look at this surgical kit, okay, we're gonna go through step by step how this progresses. So this is, like I said, like a book. You go from the upper left, go across and down, okay? So you start with the Lindemann drill, which is here, okay, to initiate the osteotomy. And the main thing is to get through the cortical plate, okay? After you do that, you go to the initial drill, 2.2 drill, and you go to the depth that you want. So if it's 10 millimeter final implant, you go 2.2 to 10, and you use that first, okay? And then after you do the initial drill, then you're gonna check with parallel pin by placing in there, check the position, angulation, and how it's positioned against the opposing tooth, okay? You want it to go to the marginal ridge ideally, okay? Then you're gonna continue with the twist drill. That's the fourth drill. And you go to the one that you are gonna go to final twist drill. And you do that sequentially, okay? So let's say if you're gonna go 4.5 diameter and 10 millimeter, then you go Lindemann, and then initial drill 2.2 by 10, and then you go to 3.5 or 3.0 by 10, and then 3.5 by 10, and then last one is 4.0 by 10 if you want to put in a 4.5 by 10 millimeter fixture, okay? After that, if it's a lower molar, you want to use a cortical drill to expand the cortical only to prevent pressure necrosis on the cortical bone, okay? And then you would want to tap, depending on which implant system you're putting. Is it IS2 implant system or IS3? Those are Neobiotech implants. The newest one is IS3, okay? But I use IS2, have no problem with that. So if I'm using IS2, I would use one of these taps. Then I place the fixture using the fixture driver, okay? The two that it says S and long, those are for implant motor engine, using with the engine. S stands for short, L stands for long, okay? Okay, so you could use that. And then the one that says 10 millimeter and 15 millimeter, those are used with ratchet or with the hand. You could deliver with the hand. If you're doing tapping, you do a tap, then you could do it with the hand. It's pretty easy because the thread's already there, okay? So after you do that, you deliver, then you finally check with a directional pin. You put this in the implant fixture, and then you check against the opposing and also against the adjacent teeth, just to verify your final position. If you're happy with that, then you go to the hex driver, you use the hex driver to put in the cover screw, okay, or healing abutment, okay? So that's it. Those are the sequence of how this drill sequence goes. This is a typical case. A patient presents with an existing bridge on the lower right, gold bridge, and patient wants an implant. So what I did was I sectioned this implant, the bridge, and polished the interproximal, and that's why you see gold flakes everywhere. And I raised the flap, okay, and I did an initial drill, and then I checked with the parallel pin. After I was happy with that, I proceeded to 3.0 drill, and then I flipped the parallel pin to see how the progression is. I'm happy with that. After all the drilling sequence, I placed the implant, and I put the position pin to check. See, this is what I'm talking about when you check against opposing. If you look at the blue position pin, that goes right to the marginal ridge of the opposing. That's where you want the position to go to. So marginal ridge of the opposing, okay? And then this is the occlusal view of it. I placed the cover screw. So here you could see hopefully that I submerged the top of the platform 0.5 to 1 millimeter subcrestal, okay? Cover screw and suture. This is a silk suture. I just did a continuous interlocking, and then final radiograph. This is 2 weeks later, just like Dr. Chen said, if you leave it 2 weeks, you'll come back with all these plaque on it, okay? For sure, patient's gonna come back. You don't want this to stay in there for too long, okay? So 2 weeks later, I just removed it. The tissue looks fine. That's it. The surgical procedure there, that usually takes about 15 minutes for 2 implants for me, or less, okay? So let's go over the implant motor real quick. This is a typical implant motor. So you have the irrigation open close valve right there it's pointing to. The handpieces for implants are usually 20-to-1 gear ratio. You could change the gear ratio on the motor, okay? And then you have the box that's the implant motor and the foot control. And so there's all these buttons, but if you just look at it, it's not that hard. You could change the gear ratio, like I said, 20-to-1, 27-to-1, whatever the gear ratio of the handpiece is. And then there's a reverse button, irrigation button, torque button, programming, memory button, and speed control. Implant motor settings. These are the settings that I suggest. When I say high speed, that's anywhere from 1200 to 2000 RPM. Average, obviously, around 1500 RPM is what I go to. And medium speed is anywhere from 500 to 1000 RPM. Average around 800 RPM. And then low speed is anywhere from 10 to 75 RPM, average 50. The low speed, I like to go even lower, maybe 30 RPM. You have better control, okay? Okay, common errors, I said it before. Doctors forget to switch from medium speed to low speed when using tap drill. This can cause tap drill to lock in bone, or possible bone fracture if you do it too hard and you don't let go, okay? Have I done this? Yes, and then there's a solution for that too. I think all the doctors that have worked with me that's done implants have in their lifetime done this mistake. It's kind of scary when you first do it, but don't worry, it's okay, it'll work out. Okay, surgical setup. This is my surgical setup typically. This is how it looks like. I have a scalpel under 24G periosteal. I'm going from left to right. Molt 9, and then a Lucas curette. Addison tissue forceps. That's not, that's the tissue forceps right next to the scissors, okay? And then I have the Kelly straight scissors. Minnesota retractor, surgical aspirating tip. I don't have the needle holder in this picture, but I normally have a needle holder. And then I have a surgical stainless steel bowl to put irrigation solution or tools that I use. Basic setup, I always have basic setup, mirror, cotton plier, and dental explorer. These are different blades. My go-to is 15 blade and 12 blade. Mostly 15. 12 blades I use for distal of a molar area if I'm trying to reflect the distal of the molar. Blade holders, there's a lot of different ones. The round one is easier to manipulate around, but I prefer the middle one, the flat one, with the ruler on the back end so I can measure the instruments, okay? Lucas curette, you should try this. It's serrated ones. If it's serrated, it's easier for cleaning out extraction sockets. Periosteal elevator, Molt 9, obviously it's pretty straightforward. I use that. This one, 24G periosteal elevator, I love this one. I use this to get started in tissue elevation. It's very easy to control, okay? That's my favorite to start. Minnesota retractor, obviously. A lot of people, if you try to use a mirror to retract, it'll put too much pressure on the angle of the lip. So Minnesota, okay. I like to use bite block so it's less tiring for the patient. And this you usually don't have to do with a newer needle holder, but if you have older needle holders, you might want to consider doing this, tuning the needle holder. So if you look at the right, you have a typical needle holder. And this is after tuning. What that does is when you're tying a knot, it'll slide off much easier if you have this tuned, okay? And then you can do this. This is an anterior case, patient presents. I just did an infiltration, that's why it's blanching just right there, a little bleeding. And I had done a bone grafting on this patient before because it was a failed implant from another office. And did a bone graft, came back. I did a mini implant. After one drill through the tissue, I checked the parallel pin, I made it wider, flipped it over, checked again, put the implant in. It's a one body implant. So if you look at here, it's almost touching the adjacent tooth because the space is lost. Okay, so I did enamelplasty to give it room. Okay, and then after that, I prepped the abutment portion here, took an impression, and this is a final X-ray that day. 1 week later, delivered the final prosthesis. Okay, this is, I think it was 3 years ago, and patients still coming to my office. We just did the maxillary tooth recently, but it's looking perfectly fine still. Okay, and it's very straightforward. You can do it. You just need to do it. Just start. Okay. And that's the end of my lecture. Thank you. I hope that that helps. And that's my email address on the upper left there. You can contact me for any questions. I'm sure you have some questions. Okay. So I'm done. I think I'm right about the right time. So I'd like to turn it back to you.
Doc, yeah, sure. Or there have a couple of questions in the Q&A, doctor, if
Okay.
you have time.
Sure, absolutely. So here
right.
I am looking at the question.
Q&A,
Okay.
yeah.
Yeah. Could you explain how the three-step twist drill works? I mean, histologically study. Histologically, I don't have histologic studies, but if you think about the three-step twist drill, I said it's for the wide diameter implant, so 4.5 millimeter or wider. So if you go, it's mainly for the mandibular molar where it's got a lot of thick cortical bone. So if you jump, if you're cutting too fast, it could cause heat necrosis. So by having 3 different steps and cutting sequentially, it reduces the heat during the cutting. So that's the premise for having 3 steps there. I hope that explains. I don't have the histologic studies, unfortunately, but by having 3 steps, it reduces the heat created during the cutting process. That's why it's 3-step tip, okay? And then the next question, I understand that cortical drill and cortical tap are used when the bone is dense. When do you have to use both? When do you have to use only cortical tap? How do you determine when to use one or both? Thank you. Okay, yeah, they're both used for cortical bone. Cortical drill and cortical tap. Cortical drill, if you try to just use, if you have a thick cortical plate, and like in the posterior mandible or anterior mandible, and there's a lot of cortical plate, if you just try to do a cortical tap after the final twist drill, there's going to be a 0.6 millimeter differential between the final drill and the cortical tap, because the cortical tap is the exact same dimension as the implant. So there's a differential of 0.6 millimeter. So if you're going on a cortical bone, trying to tap a 0.6 millimeter differential straight, you might not even get to tap because there's so much resistance. So if you try to do that, I'm sure if you try, you'll see that it'll get locked because there's too much resistance. Even at 50 newtons per centimeter, it won't go all the way down. So then you have to take it out and do a cortical drill first, and you go past the cortical plate. That's all you want to do, and it just widens it a little bit. It doesn't go all the way. It doesn't go to the exact diameter. It widens it, so instead of 0.6 millimeter differential between the final twist drill and the implant, there's half of that. So now the tap, you can go in, and it's easier to tap. So you would use both if you have a thick cortical plate. In situations where you're only using just the cortical tap or the tap drill, it might be a thinner cortical plate, or like maxilla, if you wanted to. The tapping drill is essential if you're gonna do immediate load, okay? Immediate load, there's a lot of things you have to consider, but you want ideal pressure on that implant, and you don't want too much force, so you're gonna always use tap drill. So that's the sequence of times that I would use just tap, okay? Okay, next one, I hope that helps. Next one, in a single implant placement with adequate bone, is there pros, cons for doing tissue punch as opposed to opening a flap? Yes. Tissue punch is much better if you have adequate bone and tissue, connective tissue. The reason why is twofold. One is blood supply. Since you don't open a flap, the blood supply stays on the bone, okay? So you don't disrupt any blood supply to the bone except where you're doing the osteotomy. So it's very favorable to the patient. That also helps in healing. There's less healing time. If you do a tissue punch, the next day patient feels fine. They go, or even the same day, patient has no pain really, okay? Because the blood supply isn't compromised. So it's best to do a tissue punch if you can, okay? The flap, when you do the flap, the pro is that you could see directly the bone level. Okay, you don't have to worry about what the implant level is and so forth. You could see it. You don't have to worry, did I go subcrustal or am I supracrustal? You could see that, okay? So the con of tissue punches, sometimes you can't see how deep the implant went in. You can check other ways, but that's one. So if I have a choice, I would always do tissue punch, okay? Okay. Next question, will patient have any symptoms with osteotomy extending into incisive foramen? Does it call for bone grafting? No, patient will not have any symptoms if you extend into the incisive foramen. Like I said, there's been cases where you've, when drilled into the incisive foramen, denuded all the nerve as far as you want, and put an implant in, no problem at all. So all the implant doctors that have done implants for a long time will tell you there's no problem with cutting or touching the incisive nerve or canal, okay? Okay, and then let's see what else here. I think that was all the, was that all the question and answer?
I think so, Doctor. Yeah, there's all the questions that you just answered, all of the questions from the Q&A. Thank you very much, Doctor. And now I will just make an announcement. I'll go ahead and share my screen here.
Thank you all.
No worries, Doctor. Thank you for your lecture. Okay, let me just share my screen now. All right, and stay connected with us on social media again. Our Facebook page is right here, Neobiotech USA, and also our Instagram page is neobiotech_USA, and YouTube is Neobiotech USA. So please follow us to see our most updated information. And also, if you are interested in taking our webinars, you can find these upcoming webinars in our website at www.neobiotechusa.com. And there should be all our webinar schedules under this webinar tab right here. And we have the second part 2, how to complete a dental implants restoration for beginners with Dr. Kent Hwang on this Thursday, May 21st. It's at a different time. It's actually in the morning from 11 to 12 Pacific Coast time. So also save this date, which is this Thursday. And we will have two webinars every Mondays and Thursday. So from one in the morning from 11 to 12 and one in the afternoon from 2 to 3. And all these courses are mentioned on first come first serve basis. So please register in advance and reserve your spot and the time period. I write it down right here. And we also have a great lecture coming up on Thursday. Just mentioned the Dr. Hwang on part 2 of the basic implant dentistry. And also in the afternoon the same day with Dr. Owen Train on all on X treatment planning and surgical sequencing at 2 p.m. Pacific Coast time. And here are more added webinars. So on Monday next week with Dr. Spencer Park on guided implant in the morning, and in the afternoon with Dr. Smiler on the maxillary zygoma implants at 2 o'clock. And then the same week on Thursday, the part 2 also with the Dr. Smiler on the same topic of the maxillary zygoma. And then in the afternoon with Dr. Mike Chen on fundamental of reach augmentation with GBR at 2 o'clock. So you can find all these more added webinars in our website here, www.neobiotech.usa.com. And also you can watch previous webinars on our website as well. If you missed some of this, there should be under this previous webinar tab right here. And you could find all these previous webinars and it's free to watch as well. And I really want to say thank you very much for those of you who stayed until the end. And also as part of our ongoing effort to provide a better continuing education courses, we really need your feedback via a short course evaluation. So one of our sales rep will email you this link to complete it, and the form should be like this. There should be more questions in the bottom. It's very simple. For many of you already fill it out, and thank you. It's very simple, no longer than take 5 minutes. So I'm looking forward to receiving this as well. And once again, thank you very much for participating in today's webinar. It's already, second webinar for today, and it's been several webinars we've been doing it. I hope everyone really learn a lot as well while staying at home. So please stay healthy, and also we hope to see you again next time. And feel free to contact me if you have any further questions. Here's my email, young.chy@neobiotech.usa.com. And if you have any further questions in regard to today's webinar topic, then you could also email to our speaker, Dr. Hwang. I leave his email address in the chat box, or you can also see it right on screen. The doctor's screen is right there. It's kenthwangdds@gmail.com right there. So thank you very much, Dr. Hwang, again for your presentation, and thank you all the doctors who participated in today's webinars. And I hope all of you have a wonderful rest of your day and stay safe, and we'll see you next time.
Thank you.
All
Bye.
right, thank you. Have a great day. Bye-bye.